Hello there, Dr. Mecham here. I'm going to tell you what you need to know as far as lab values for these bone diseases that I've discussed in previous videos. And so this is kind of a cheat sheet for those most likely to appear on board exams down to least likely. First one, definitely one that you have to know, is Paget disease. Notice that the only thing about this is ALP, alkaline phosphatase, is high. Now, you'll see that ALP is high in a lot of different diseases, as I've said before, but it's really high in ALP, and you don't see any other abnormal values. And in fact, in Paget disease, you'll see that it's multiple times higher than normal, sometimes up to 10 times as high as normal. And so that should really stand out, and that's number one. Number two, I would say, is to know hyperparathyroidism. This is the most common cause of high calcemia. In fact, look at that. If you see high calcium, as far as the diseases we've talked about, that's probably going to be the culprit. So hyperparathyroidism. And if you see high calcium and high PTH, it's pathognomonic. You know it's hyperparathyroidism. So briefly, why does it occur? So there's something continuously causing an overproduction of PTH, usually that benign tumor on one of the glands. And that causes a high PTH despite high calcium levels. So PTH draws calcium out of the bones. It increases the calcium. In most other cases, if you have high calcium, that's going to lower PTH. All right, then how about Rickets and Osteomalacia? Remember, by definition, those are the low vitamin D diseases. And so you have low vitamin D. And what does that do to our calcium levels? Well, low vitamin D means you're not absorbing enough calcium from the gut, so that can frequently be associated with low calcium. Remember the calcium Nazi, PTH. As soon as calcium starts to drop low, your body starts to upregulate the amount of PTH that's created. And that signals the kidneys to retain as much calcium as possible at the expense of phosphate. And so phosphate is going to be low as well. So the pattern is low vitamin D, low calcium, high PTH, low phosphate. Then renal osteodystrophy, sometimes called secondary hyperparathyroidism, but it's related to kidney disease or sometimes kidney failure when the kidneys are not functioning at all. So the kidneys are unable to retain calcium from the urine. So calcium loss leads to low calcium levels, as we see here. That causes the PTH to kick in, as we would expect. So high PTH. So far, it's just the same as Rickets. But what's different? What's different is phosphate. And remember, I said to think of phosphate as being available in excess. And if the kidneys aren't functioning, they're not able to excrete enough. And so you have low calcium levels, but you're holding on to more phosphate than you would like. And so you have high phosphate levels. And that's what differentiates it from Rickets and Osteomalacia. Then additionally, that high PTH is going to stimulate that final production step of vitamin D in the kidneys. So it causes hydroxylation of that final step. And what that does is it depletes what I talked about as the storage substrate of vitamin D, which only has one OH group, and that causes that to go down because it's constantly being depleted. And so measured vitamin D levels can be low in renal osteodystrophy. Now, you might ask, why isn't vitamin D shown as low in hyperparathyroidism for the same reason? Because you have high PTH. I don't know. Nobody really knows. Actually, it is often low in hyperparathyroidism as well. I'm not sure why the books don't report it, but you will find that if you look at lab values for certain cases of hyperparathyroidism. But regardless, you already have a slam dunk way of recognizing hyperparathyroidism and starting with high calcium. But if you have high calcium and high PTH, you know 100% that's going to be a hyperparathyroidism. All right, what about hypoparathyroidism? Well, that's just the opposite of hyperparathyroidism, so you'd expect basically the opposite lab values. So if you have low calcium, low PTH, that is pretty much pathognomonic for hypoparathyroidism. All right, what about hypophosphatemia or hypophosphatemic rickets? Well, that's a disease where the kidneys are no longer resorbing phosphate, resulting in a low phosphate. That in turn activates the 1-hydroxylase in the kidneys, so again, increasing that active vitamin D production, which could result in low measured values of vitamin D, that intermediate one, which is the one that's typically measured. The active vitamin D results in bone resorption in the absence of healthy phosphate levels. So calcium is normal, PTH is normal, but we have low phosphate and we have high ALP due to increased bone resorption. All right, jumping now to hypophosphatasia. And although this is rare, it's really easy to identify because it's the only one really showing low alkaline phosphatase levels. And so if you see low ALP, that's pathognomonic for hypophosphatasia. Other values are typically normal in that. All right, that's your overview. Hopefully you know these patterns and you'll be well prepared for your board or examinations. Let's do a quick test for you guys. So looking at these lab values, I gave you reference ranges. What disease is it? Well, what's high? Here's PTH. Here's calcium. Do we need to go on at all? Right? High PTH, high calcium. Remember Captain Obvious? That is hyperparathyroidism. I did give this as an exam question once, and several students were confused. There's high ALP, but remember that can happen in a lot of diseases. It's not super high like I would expect for Paget disease, but it is a little bit high. What about this one here? This is confusing. There's low vitamin D. And so people right away want to jump to Rickets or Osteomalacia if it's an older patient. But pay specific attention to which form of vitamin D this is. This is the 25-OH-D. Is that the active form of vitamin D? No, the active form has two OH groups, which is the 125-OH2 vitamin D. And so this is the intermediate one, which I said typically they measure when they're doing vitamin D measurements because it's abundant in the body, it's abundant in the serum, it's easy to measure. But what can happen in hyperparathyroidism and some other diseases, if you have high PTH levels, that's going to activate that hydroxylase in the kidneys to form the active form. As it's doing that, it's depleting this storage form of vitamin D. And so you'll get lower 25-OH-D. And so only in certain circumstances are they actually going to test for the active form of vitamin D. And that's it for this lecture. I'll leave you with this quote from Mr. Glass, who the entire series of lectures I just gave you was themed after. And Mr. Glass approves. We're now done talking about all the bone diseases. Look me up, email me if you have any questions. Thanks, and see you around.